Hello everybody. Today we are going to discuss the management of hyperglycemic hyperosmolar syndrome in short. So the precise definition of HHS has not been agreed, but there are characteristic features that differentiate from the hyperglycemic state such as DK. And the characteristic feature of the person with the HHS are marked hypovolemia, measured or calculated serum osmolality more than 320, then marked hyperglycemia, then without significant hyperketonemia, and without significant acidosis. Now, the assessment of severity. Care for patients with HHS can be complex because they often have multiple comorbidities and may require intensive monitoring. The presence of one or more of the following should prompt discussion because they indicate the need for admission to high dependency unit and the level 2 environment. Like measured and calculated osmolarity of more than 350, sodium more than 160, venous and arterial pH less than 7.1, hypokalemia or hyperkalemia on admission, GCS less than 12, or abnormal AVPU scale. Oxygen saturation less than 92% on air, systolic blood pressure less than 90, pulse more than 100 or less than 60, urine output less than zero point 0.5, serum creatinine more than 2, or acute kidney injury, hypothermia, microvascular events such as myocardial infarction, stroke, and other serious comorbidities. HHS is not associated with significant morbidity and higher mortality than DK, but must be diagnosed promptly and managed intensively. The goal of treatment of the HHS are to treat underlying cause and the gradually and safely. The first one is normalize osmolality, replace fluid, electrolyte losses, normalize blood glucose. The other goal include arterial venous thrombosis, other potential complications like cerebral edema, cerebral pontine myelinosis, and osmotic demyelination syndrome and foot ulcerations. Now management timeline. So within 0 to 60 minutes, that is intravenous fluids are commenced. If there is a problem with the intravenous access, critical care support should be requested immediately. So we should start with 0.9% sodium chloride, 1 liter to run over 1 hour. Consider more rapid fluid replacement if systolic blood pressure is less than 90. Caution in elderly where too rapid rehydration may precipitate heart failure, but insufficient may fail to reverse acute kidney injury. Only commence insulin infusion quickly in the following circumstances. If there is HHS and the ketonemia, that is blood ketone more than 1, or less than 3, or urine ketone less than 2, and if a patient is not acidotic, that is venous pH is more than 7.3 and bicarbonate more than 15, then use 0.05 units per kg per hour. If there is significant ketonemia or ketonuria, that is blood ketone levels are more than 3, or ketonuria, that is urine ketone level more than or equal to 2, with pH less than 7.3 and bicarbonate more or less than 15, then use DK guidelines of treating like 0.1 unit per kg per hour. Then we need to assess the patient clinically. Does the history suggest sepsis, vascular event, or recent change in the medication? Assess the degree of dehydration. Examine for the source of sepsis or evidence of vascular event. Mini's mental state assessment for cognitive assessment. And then assess for the contraindication of low molecular weight heparin. Then assess for the foot risk score. Assume high risk if the patient is obtunded or uncooperative. Ensure heels are offloaded and ensure daily food check. Then regarding investigation, capillary blood glucose, venous plasma blood glucose, urea and electrolytes. Then measure or calculated serum osmolality, that is 2 into sodium plus glucose plus urea. Until the urea is available, calculate using 2 into sodium plus glucose. Recalculate osmolality once the urea is available. And then use the correct formula, that is 2 into sodium plus glucose plus urea. Then Blood gas for pH, bicarbonate, lactate, and electrolyte. Capillary blood glucose, full blood count, blood culture, ECG, chest X-ray, urine analysis, and culture, CRP. Then regarding monitoring, establish monitoring regimen appropriate to the individual. Generally, hourly blood glucose, sodium, potassium, urea, calculated osmolarity for the first 6 hours, then 2 hourly osmolarity if the response is satisfactory. Chart measured or calculated osmolarity, glucose or sodium, continuous pulse oximetry, and continuous cardiac monitoring. Then next 60 to 6 hour, treat the underlying cause if known. To achieve the gradual decline in osmolarity, we should use the 0.9% sodium chloride solution. Aim to give further 0.5 to 1 liter per hour, depending on the clinical assessment of dehydration or versus risk of precipitating heart failure. The target is to achieve the positive fluid balance of 2 to 3 liter by 6 hours. Measure glucose, urea, and the electrolyte hourly and calculate osmolality, that is 2 into sodium plus glucose plus urea. If plasma sodium increasing but osmolality declining at appropriate rate, continue 0.9% sodium chloride. If plasma sodium is increasing and osmolarity is increasing, check the fluid balance. If the fluid balance is inadequate, then increase the rate of infusion of 0.9% sodium chloride solution. If osmolarity is increasing and the fluid balance is adequate, then consider switching to 0.45 sodium chloride at same infusion rate. If osmolarity is falling at the rate exiting 8 mmol per kg per hour, consider reducing infusion rate of IV fluids and or insulin. If glucose is falling, uh, if uh, if glucose is falling less than 5 mmol per liter per hour, check the fluid balance. If positive balance is inadequate, increase the rate of infusion of 0.9% sodium chloride. Fluid replacement should be adjusted for those who are less than 50 kg body weight or with pre-existing heart or renal disease. More caution fluid replacement is necessary. For example, 0.25 ml per kg per hour as commenced by NICE. Only IV insulin once the fluid replacement is adequate and glucose concentration have plateaued. Starting IV infusion too early could result in circulatory collapse. If positive fluid balance is adequate, then start with the insulin as fixed rate, infusion rate at 0.05 units per kg per hour, or if already running, increase the rate to zero point 0.1 unit per kg per hour if glucose concentration are not falling. Maintain the potassium in the normal range. Hypokalemia, hyperkalemia, these are the life-threatening condition and warrant senior review. They are less common in HHS than DK, but monitoring and replacement is necessary. So replace the potassium according to the following. Like if the potassium is over 0.5, then do not replace the potassium. If it is between 3.5 to 5.5, then replace the potassium like 40 ml per liter. And if it is below 3.5, then senior review for additional potassium replacement is needed. Then we should avoid the hypoglycemia. Like aim to keep blood glucose like 10 to 15 ml in first 24 hours. Then if blood glucose falls below 14, commence 5% to 10% glucose at 125 ml per hour and continue 0.9% sodium chloride solution. Monitor vital signs and chart national early warning score. Check the ketone concentration hourly if HHS is resolved. Until HHS resolution, maintain accurate fluid balance chart. Heel protector and appropriate mattress should be provided for those with immobility, neuropathy, peripheral vascular disease. Then next 6 to 12 hours, ensure clinical and biochemical parameters are improved. Continue charting blood glucose hourly, sodium and calculator osmolarity 2 hourly. Take appropriate action. Continue IV replacement to achieve the positive balance of 3 to 6 liter by 12 hour and maintain the accurate fluid balance chart. Assess for complication of the treatment like fluid balance, cerebral edema, cerebral pontiff, myelinosis. Continue treatment of any underlying precipitants. If the patient is not improving, seek senior advice. Then we should avoid the hypoglycemia. Aim to keep blood glucose of 10 to 15 mmol in first 24 hours. If blood glucose falls below 14 mmol, then commence 5 to 10% glucose at 125 ml per hour and continue 0.9% sodium chloride solution. Ensure referral has been made to the diabetes. The next 12 to 24 hour, ensure continuing improving the clinical and biochemical parameter. Continue charting blood glucose hourly. Measure sodium and calculated osmolarity can be reduced to 4 hourly if improvement maintained. Do not expect biochemistry to have normalized by 24 hours. Take appropriate action as outlined above depending on the result. Check ketone hourly until HHS resolution. Continue IV replacement to achieve remaining replacement of estimated fluid losses within next 12 hours. This will be depending on the factors such as initial degree of dehydration and body weight, and most importantly, the response to treatment so far. Therefore, continue maintaining accurate fluid balance chart, plotting osmolality, make appropriate adjustment to the fluid replacement rate. Continue IV insulin with or without 5 to 10% glucose solution to maintain blood glucose 10 to 15 ml per liter. Adjust the insulin infusion rate hourly by 1 unit per hour increment or decrement to achieve desired blood glucose. Assess for complication of treatment, for example, fluid overload, cerebral edema, central extrapontine myelinosis, osmotic demyelination syndrome. Continue treatment of underlying precipitant cause, and if the patient is not improving, seek senior advice. Then next 24 to 3 days, the individual should be steadily recovering, begin to eat or drink, and the biochemistry is as it was prior to the acute episode. Ensure clinical and biochemical parameters are improving or have normalized. Continue IV fluid until eating and drinking normal. Variable rate of insulin if not eating or drinking. Convert to appropriate subcutaneous insulin regimen when biochemistry is stable. Encourage early mobilization. Daily urea and electrolytes. Remove urinary catheter when clinically appropriate. Assess for the signs of fluid overload and cerebral edema. Assess for the evidence of continuing sepsis. Daily food check. Then continue low molecular weight heparin until a day of discharge. Ensure that the person has been reviewed by diabetes team. Thank you guys.